Okay. So Shannon Johnson, the director of the behavioral health market with Humana. I'll let you introduce yourself, and if you want to give an overview, and then others want to introduce, Debbie and Jason, just kind of where you're located and whatnot. Is that what you're kind of looking for, Shannon?
Yeah, sounds good.
Okay, perfect. All right.
Sure. So thank you all for joining us today. Just want to tell you a little bit about, Dana and I, we are with Humana. We sit on the corporate business development team for Medicaid. Lots of folks know Humana as a Medicare Advantage organization. We actually have a relatively large footprint in the state of Illinois currently. We were just recently awarded the FIDE SNP plan award. So that's the fully integrated dual eligible and special needs plans that were just announced. And what we do is we kind of look at business development or unpacking a state's landscape. We're doing all that, and we do this in tandem with one of our regional vice presidents and an additional strategy advancement advisor. That's who Chris is and who Brooke is on our team. But Dana and I really focus on the behavioral health challenges and everything that falls into that umbrella. So we want to know kind of what's happening again, locally, what's important to legislators. And Medicaid is actually our fastest growing line of business, and we are preparing to respond to the Illinois Health Choice RFP that we expect to come out later this summer. And that's going to be we got moms and babies, expanded population, age blind and disabled, non-dual eligible members. So we are just on a listening tour, if you will. And we like to talk to various stakeholders. We'll talk to provider organizations. We've talked to NAMI. We talked to Mental Health America. We've talked locally to the Community Mental Health Association of Illinois. So I say all that to say that we really are just here to listen to you all. What's happening in your communities? The good, the bad, the ugly. What's happening, in the behavioral health landscape, whether it's substance use disorder, is it child adolescent, is it seniors, is it veterans, is it the unhoused? So I'll stop there and turn it over to introduce Dana. But I wanted to give you just a little bit of overview, and then I know Jody's going to show a few slides high level. This is very high level. It's meant to be very conversational, very informal. And I just look forward to the time, and thank you for giving us that time. And Dana?
Perfect. Good afternoon, everybody. I'm Dana Stiggers. I'm a market development advisor on the corporate Medicaid team. I'm actually on Shannon's team. We are on business development. And like Shannon said, we are on a listening tour to really learn more about the gaps and opportunities that exist within the Illinois Health Choice opportunity. We have about 270 Medicare lives in the state. So we are just happy to learn and listen and again, unpack that behavioral health landscape.
270 or 270,000?
270,000.
That's better. Okay. All right, Jody, we'll hand it back to you and your team.
Okay, so I'll start with Jason Holcomb, who's our ACMHAI president. And I'll let Jason go ahead and introduce himself.
Hi, Jason Holcomb, Director of Community Impact for Region 1 Planning Council in Northern Illinois. I serve as the director for our county mental health board, which is in Winnebago County. We have a 0.5-cent sales tax for mental health. And then the president for the state association, ACMHAI. I've been in variety of mental health type positions, community systems positions for the past, feeling old, the older, more years I say every time feeling older, but like let's say 15 to 20 years now. And then most recently I've been doing this work here with the mental health board for the last 5 years almost. And so, I mean, I think I'll just speak about the Winnebago County context, but then I think this affects a lot of members, but we're just really struggling with workforce here. I think that's the one of the major primary issues for behavioral health providers across the state. So that's a challenge. I think what's unique to the state of Illinois is also the crisis response. I mean, 988 is something that's affecting every state, but in Illinois, there was also the Community Emergency Services and Support Act legislation, which dictates the removal of law enforcement from crisis response. And so we're all kind of participating to some degree in these various regional coalitions and advisory boards to try to figure out what the future of crisis response looks like and what all of the coordination needs to be from mobile crisis response teams, 988, 911. Some of us, many mental health boards, because we have local sales tax, we had already been funding kind of alternative response teams because the state really wasn't doing that, and because there was the need. So now we're also trying to each figure out how do our kind of custom designed, locally funded alternative response teams, those of us that have them, how do they fit into this landscape as well? So there's a lot going on with that. And then, so if I had to say like 3 top things that I see both locally and that I've heard from other member boards throughout the time that I've been part of ACMHAI, would be workforce, crisis response, and then I think the third would be care coordination. I think there's just a complete lack of care coordination in the state of Illinois. I think it's pretty much the Wild West in terms of providers. It's like just whatever funding they can get. They're accountable to those funders independently and individually, and often have multiple funding sources from fee-for-service, managed care, Medicaid, private insurance. Then there's grant funding they're getting. Some of that's coming from the state, multiple departments in the state. And then you have your local foundations, mental health boards, etc. And there's really not any coordinating entity that works across these different payer types and helps establish, collaboration ground rules.
That's fair.
Thanks, Jason. Debbie?
Hi, ladies. Deborah Humphrey, Executive Director of the Madison County Mental Health Board. As I was sharing earlier, we're housed in the southern region of Illinois. We're the 9th largest county in Illinois, population 260,000. I've been with mental health boards for 26 years. I was in partnering county, St. Clair County for 20 years, and I've been in Madison County for 6 years and retiring at the end of this year. So I've done 45 years in mental health, behavioral health. I start out working in the hospital setting, inpatient hospitals, always had director managing positions throughout. So I've seen it from the community level. I've worked in, ran a crisis residential programs for children and for adults. So I've seen hospital inpatient, I've seen as a provider, as I said, and then on the government end of it. So just really a broad array of different experiences in each of those areas. Looking at Madison County, one of the things that mental health boards do, we do a 1 and 3 year strategic plan, but generally we're also doing needs analysis. So I think each of us, we always say, if you've seen one mental health board, you've seen one mental health board, because even though there's some similarities across the board and many of the things that Jason said are things that we experience as well, but then there's always those unique things depending on where you're located in terms of even revenues that flow in and out. Chicago area, I say we're the blonde-haired, blue-eyed stepchildren, because Southern Illinois doesn't get the lion's share of funding that they get up north, but also it's higher populated than we are. So there's that balance there, but we still have needs. We have some other needs that are unique sometimes, because sometimes we have the inner city population, but we also have the urban, and then we have rural areas. So in Madison County, we face all 3 of those. So the geographical area can sometimes sometimes be a challenge and a barrier for individuals in terms of seeking services, just because wherever those services are located, if they're not located in proximity to a rural area, there's challenges for access to services. So, looking at the big ones, again, back to where Jason was at, we've kind of come to the realization that care coordination really is one of our biggest issues. We fund here 17 different organizations through one singular fund that we have here through our tax levy. And then we have a second fund that's called System Development, which supports trainings and other support or one-time events. But the mental health aid agency that we fund, actually 16 agencies, but 4 agencies, we also have opioid settlement money that we fund. So there's just one additional agency that we brought in, which is a hospital, which is our first time funding a hospital. With our revenues, and as we look across, again, the county and looking at all of the needs and look at all the services that we provide a large array of services. But what we're finding is, if someone's in the hospital, so they've used crisis services, now they're in the hospital, now they're coming back to the community, do they get re-engaged back to a mental health provider so we don't see them recycling through the system? We're finding that those connections aren't tight. They're not what they should be. And I know through my career, I've had meetings like this before when I was in St. Clair County and trying to bring the hospitals together and bring the major mental health providers together and say, let's put on a transition meeting before it's time for discharge. Let's get these individuals a plan in place. When they're discharged, they're going to go to this facility and they're going to get, an intake, or if they've got an intake, we're going to re-engage with the therapist. But none of that's really playing out. And I think people change in positions. We are a society that in behavioral health, like anywhere else, probably, someone's there for so many years and then they're somewhere else. And so you lose that knowledge base and that working together and that connectivity. And so one of the broader things that we're looking at trying to break, we've started a behavioral health network council that's bringing the hospitals, the local providers, and beyond that. Right now, we're starting with the local providers, the main mental health providers, the main substance use providers, the hospitals. And then once we get that form, we're going to bring in transportation systems. We're going to bring other support systems in there. And we're looking at different models like Gelada. We're looking at Choir, different systems that would support these entities and bringing everybody together and connecting point A to point B, and that everybody can access to that individual, although HIPAA compliant and meeting all the privacy type things, but being able to ensure that these individuals don't get dropped here and that someone's got oversight and seeing when they need to go here or there or what service that they're needing. So that's kind of one of our biggest ones, and that access plays into that as well. Is we did a behavioral health transportation summit last year because forever we've heard people don't get to appointments, they don't get to what they need because we don't have transportation. Well, after that, we found out there's a lot of transportation. It's connecting to the transportation. There are still gaps. Definitely, there's always still gaps in all of this. But if we can get the system of what is there working better, then we really know the true gaps and we know what we need to put in place to fill those gaps and barriers. And so that's one of the bigger things that we're looking at, kind of the I won't say subpopulation, I started to say subpopulation, but some of the other areas I think we're looking at. Again, CESA, I'm on our advisory, Region 4 advisory, and we're working through that with 911 and PSAPs and trying to, again, I think back to the local communities, looking at the players that are involved in making that system, crisis system work. Is what we're working at trying to make happen right now. And I think that's throughout the state. They really kind of kicked it back to the local communities to say, you guys get together. And so we're piloting a couple of efforts down here in Madison and St. Clair County. But the homeless population is a big issue for us. We work real close with our public health department on a lot of this. Their same plan mirrors our plan, and it's all behavioral health. Suicide, opioid overdoses, and opioid, and what were the three? Suicide, opioid. I'm missing one for right now. I'll get back there, but there's actually three of us that we parallel on, and we're right now revisiting their plan right now. We're developing a new one, but we've got a lot of unhoused people, and no one wants them in their backyard. The NIMBY philosophy is like, we've had organizations. We have money. We have $3 million to dedicate for a building, and we can't get any city to pass to allow it to come in. And we've got agencies that are willing to do it, to build, to run it. And every, we had warming centers, people were out in the cold, and even that was a challenge to get those off the ground. But we finally got what's called the OWL. We've got 3 or 4 municipalities that have gone on their own and implemented some warming centers so people can at least be brought out of the inclement weather, whether it be very hot or very cold. Suicide and opioid, our rates are higher than the national and the CDC national and state averages for both. Our overdose rates have been extremely high, and currently we've actually seen a decrease. I don't know if it has to do with us implementing our opioid. We hope that some of the money we've invested since 2023 is making an impact. We do outcome measures and everything, but it's hard to know, again, community-wide, is that the one thing that's having the impact, the things that we've created through that. But we have seen a small decrease in those numbers, so we're happy with that. I think 15 less deaths at this point in time this year than we had last year. So we're happy about that. Workforce is an issue here as well. Children's mental health is where we were seeing the biggest issue for us. And we've tried to do some creative things around working with the behavioral health workforce group that we developed with the Illinois Behavioral Health Workforce Center. We developed a curriculum through one of our local colleges that would be a certification. Well, it was started to be a certification, ended up being an applied science, a 2-year program with an internship that they would be in an agency. And we had some funding through December of this past year to help with that. And now we're working on a certification program that we're looking at a model in Maine to see if we can bring it to Illinois and sell it to Illinois Department of either mental health or HFS or whoever we need to go before to get this certification program that would get trained staff at a much earlier time than having to wait for somebody to get a 4-year degree, but that they'd be experienced, trained, and knowledgeable of in the areas that they need to work with children and families. And then jail mental health is a big issue for us, people being left in the jails for long periods of time. We have one person over 1,000 days who was assessed as needing mental health treatment. That's just one individual. There's many individuals that are there way longer than what the state has in terms of the length of stay that they're supposed to be moved. And I know that we had a webinar just recently, Jody put together, that the state is looking at addressing that. And for our area, it looks like we're going to get 100 new beds at our mental health, state mental health center is going to open an area they're renovating. It'll be available 2026. So that'll kind of be a remedy for that. But right now, our opioid money, we put a full-time counselor in there, and we brought in MAR services through the mental health board for the opioid money that we have to try to remedy some of that for the jail until we can get people moved to the appropriate facility. I think I'll stop there. I think those are kind of the biggies for us.
Debbie, that's awesome. And thank you, Jason, and for taking that time. I kind of outlined some themes, but hey, if I could just maybe take a step back, I'd like to introduce Chris Hansen, or let her introduce herself. She is the regional vice president that's heading up this Illinois opportunity, and Dana and I work with she, and And Brooke, I think, as I mentioned earlier on the call, she's a strategy advancement advisor. But Chris was tied up in another commitment. So, Chris, I'm so glad you could join. And if you wouldn't mind, just a quick introduction, and then we can go from there. I've got a lot of notes here. Jason and Debbie shared a lot of information about some challenges in their particular areas. And but I'd like for you to have an opportunity to say hello.
Hi, and yes, I'm very sorry for being late to the conversation, and I probably missed a really good portion of it, my first 15 minutes here, and I'm sorry, Jason, that I missed the discussion from your area, from your county. But I'm Chris Hansen. I am the market vice president overseeing the Midwest, and specifically our growth and strategy for our Medicaid and integrated dual special needs programs, some more of the complex programs. Really, at this point, I know Shannon probably already pointed out, we're really trying to understand, Illinois and the needs in Illinois, and kind of where we can take a step back, using Shannon's language too, and really understand how we can partner with organizations and counties and communities like yourselves to design a process and a program that's really going to fit. So to address the needs. So thank you for taking time again to meet with us, and really enjoyed hearing what you had to say and your input, Deborah, and look forward to more.
Perfect. So just to on kind of on the heels of that. So I know that, Jody, and again, I really appreciate you putting this together. I think when we talked, this really what is very just much really just really want it to be conversational. So since there is just a few of us, is there some other things either Jason or Deborah you guys would want to share? Again, not necessarily speaking for your peers in other areas, but if you had to just take that 10,000 or 50,000 foot view from the state, in addition to say workforce, obviously care coordination came up a lot, the crisis response team, and then Deborah, the kiddos and justice involved. Are there any things happening across the state that you think that are going very well? Like, are you seeing things in your communities that are working really well that you want more of? Because I've heard you guys, it sounds like you're tapping into the opioid settlement funds. Jason, you mentioned you had a 0.5-cent tax on that was contributed for mental health. Do you think collectively there's in any singular or a trend of things that are happening that are going very well from a mental health or behavioral health standpoint in Illinois that you would share with us?
I think there's a lot of things to point to. I mean, even the SESA legislation, which I talked about, as challenging as it might be for us to coordinate, it is something the state is doing to try to move out of a system, that maybe wasn't working. And, so I think it is, in some ways, it is a good vision. It's just challenging coordination side of things. The Medicaid demonstration projects have been good. And I know also then the CCBHC funding that the state of Illinois has received through the state. And I think there's 2 counties right now, Winnebago County and Champaign. Well, actually, doesn't Madison County have a CCBHC as well?
We have two.
Two. So we have numerous CCBHCs now. And I think that was kind of led by the state. So in terms of getting that federal, being part of that federal designation and pilot. So that's good. That's been great. That's a really nice funding model, and that in some ways maybe is the answer to care coordination down the road. Once we kind of fully build that out, we'll see how that all plays out. There's still a lot of providers providing services depending on which county you're in. So I don't know, how the other providers are incentivized to participate in that kind of care coordination. But I think those are some good positives that are happening in the state. I'm sure there's numerous other ones. Oh, on the workforce, even, I will say, I think the state's done a good job of, Debbie spoke a little bit to the plans that have been developed around that. And one thing they've done a really good job with is building out the peer recovery support specialist pipeline. And that's significant because that is the thing that's the quickest, right? Like
Mhm.
building out, social work pathways, which we are trying to do in Winnebago County, is great, but it's even if you identify, kids coming out of high school right now, it's 5 or 6 years to graduation with a master's degree. So peer recovery support specialist would maybe you're doing 1 year of classes and paid internship before you're workforce ready is meeting the need quicker.
Yeah.
On the peer recovery support specialist pipeline, are you having tremendous success in recruiting like high school students at this point, and actually completion of the,
No, we visited that with our certification with some of the other things we were looking at too. And providers will only hire 21 years of age and older. So we're still not able to get younger. They do that with health. They can do it with the health workers, but not with the behavioral health providers. They all start at 21 years of age.
liability reasons?
I'm not sure. But that's kind of the criteria or eligibility for employment. I don't know if that's a state mandate. I'm guessing.
Yeah, because I could see how, coming out of high school, especially for certain populations, it'd be so beneficial.
It is, and we do the 2x2 programs down here, which is 2 years in high school. They actually take curriculum for college and they count as college credits. So they do some medical ones, and it'd be great to have that for behavioral health because we visited that. But again, the provider said we can't hire them. So might as well start at more the associate level degree instead of the 4 year, do the 2 years. So that's why we went that direction. But the peer recovery support specialists have, as Jason said, that has been successful. I know we have one agency that started, I want to say 3 years ago. They have 30 peer recovery support specialists in our area. And they walk with individuals from, anytime, whatever they need, they're there. And we've facilitated getting them a vehicle through our transportation summit, and they are able to pick people up whenever they need to get them wherever they need. And they do wraparound services, comprehensive wraparound services with the individuals to support them through it. So I think, again, that's impacting our numbers as well. Because they're able to sustain recovery with that type of support. And that's really what they need. And we have it for mental health and substance use. They're both.
That's great.
2 different curriculums.
That's really good.
What organization, I'm sorry, what did you mention the organization, Deborah, that's in Madison County that's got the 30?
It's ACMHAI, AMARE is the name. And if you guys want any follow-up with this, I'd certainly be able to share anything that you might be interested or direct you to our website, whatever works in terms of follow-up information. We can provide some additional information if you want to reach out to anyone. The other thing back to Illinois Behavioral Health Workforce around that area, the Behavioral Health Workforce Center is really doing a great job around the children's area. And we just had a training or a presentation, I guess Monday, with our Illinois Children's Mental Health Partnership, which is making lots of inroads here and around the children's mental health world. We have a Children's Mental Health Act in Illinois, and there is a plan, and Dana Weiner, who has presented to ACMHAI a number of times, but she's been playing a role in the Illinois Children's Mental Health Partnership as well, have really been working on lots of different areas. But Illinois Workforce was there as well, and they have done a lot with children and family supports. And I have a presentation that's really good that I can share with you that can give you more detail of some of the things that they've implemented around helping children and families. One of the other things that I thought about too is they've integrated in Illinois, they've integrated the Department of Mental Health and what was called Supra. So now that's our substance use and our mental health are one. At first, I wasn't sure when I heard that, but we know that there's that connection there. So we'll have to wait and see how that totally enrolls because it's fairly new. But I think that could be a real positive, that integrated care for individuals that have mental health and substance use disorders.
I think, coming from a health plan perspective, but also working on the behavioral health side and at a state level, providing services and supports for state funded services that were outside of the Medicaid program. One of the things that have always been a bit of a gray area for us on the health plan side is how do we best work with the counties? How do we're doing stuff over here, you're doing the same, some of the things over here. How do we come in the middle and really, create something that, together is beneficial for the community? Because oftentimes I'm sure, we're touching the same individuals, how do we better coordinate services and provide support to you and your community members? Has anything been successful? Is there any model out there that's been successful yet with a health plan included in any of those efforts?
A good question, but not to my knowledge.
Because I was thinking with all of the opportunities to design like value-added benefits, and funnel, maybe additional dollars into the community, and joint efforts, there could be some great opportunity to come to the table a little bit more.
I mean, I think there are models of states that do it differently and maybe distribute some of that funding directly to smaller regional bodies. I think the state of Illinois at one point in time did that, and maybe like in the mid 80s kind of centralized it because of the issues of Chicago being so dramatically different than the other areas. That's my kind of understanding of the history of it. I could be wrong about the details, but if you look at what's happening now, I think the state of Wisconsin still distributes, if I'm correct, their Medicaid funding right to the counties, and the counties kind of then have a stronger role in care coordination. And I know in Arizona, it's kind of limited on to their crisis response work, but they have like regional advisory bodies that get braided funding, like funding from multiple revenue streams that kind of are aggregated to fund the crisis response behavioral health services. And I think that includes 911 to a certain degree. And they kind of then have more of a coordination role in that, or they can, and I think, I don't know how that's not going to likely be accomplished through mandate, but can some of that be done through just willingness of funders coming together, whether it's regionally or at a county level, to say, we are going at a funder level going to try to map this out a little bit better and understand where the gaps and redundancies are, and where the just lack of kind of like connectedness, linked ecosystem kind of opportunities. That would be interesting, I think, but it would have to be kind of done as a coalition of the willing, because it's not a mandate.
Well, I could see being so impactful too, coming to the table, like your mention of, the significant homeless population, Deborah, we're trying to help solve for that too, and reach those members who are homeless, and try to get them housed. And, we're working on some of our similar efforts and trying to create strategies around that. So I always think it's best to kind of get all the great minds in the room who are doing the same thing within the same community, and come up with a solution rather than us pursue something siloed and separate. So and you obviously have more experience. You're on the ground. You're right there in the counties. So I could see sans that mandate, maybe there is a great opportunity for us to try to do something quarterly, and maybe garner additional attention to get others involved, but definitely it would be impactful on our side.
Well, I was thinking, I was trying to kind of strategize in my brain how to make it work. And I was thinking back to the care coordination group that we're designing, to have one maybe like on financing. Some of the same providers would provide valuable information around that because they do the Medicaid billing and they're doing insurance billing, and so they have more of a total picture. It's like here I get, a lot of the numbers and reports that I get, I ask for what the mental health board's funding. I want to see the numbers that we're funding. Now I get numbers like other individuals that they serve, but I don't know anything about the financing part of it. I don't know who's their payers for those services and what they're paying for. I don't have any knowledge base on any of that. But I think it would be a really great conversation to look at all of that. I do know that we did identify where the gaps were, and we actually funded an organization to see people who were uninsured. And in a whole year, they saw 5 people. And they gave out their number. They marketed, only 5 people ever received any kind of mental health services for a year. So we didn't keep our money there. We moved it somewhere else, because it was enough money to do quite a bit. But I would be really interested in having that conversation and having a group to really share, from their perspective or where they're at and their knowledge of that.
Yeah, that's an interesting, Chris, to your point, and then Deborah, what you're saying, I guess, thinking about your roles and that you're connected in your various communities, towns, and counties, having these relationships with some of these key providers, I think having a provider forum, this is something that I've been a proponent of forever. I've got a very long career in behavioral health and started out on the provider side, but I really like provider forums. I really like a way to bring kind of eclectic providers, SUD, maternal health providers, folks who are actually where the rubber meets the road, and talking with them about those challenges. Because to your point, I love what you said about the transportation component. When you got together, you found out there is a lot of transportation. Every single plan, we're going to be required to provide as a covered benefit non-emergent medical transportation. It's that coordination and someone knowing to call this group versus that. But I love the idea of maybe having a provider forum or something like that, Chris, to really hear from folks. It was really successful in another state that we did some work in, because initially I think everyone was a little bit apprehensive. What does this payer want from us? What do they, what really all we were trying to be is a convener of just these various avenues, because we are touching some of the same folks. We have different capabilities and strengths. And, what we found in some of these conversations is that, man, this was really powerful stuff. And we learned a lot about things that were available that we weren't really taking advantage of. And just like you said, you don't want to put your money where you're only helping 5 folks, but you didn't know until you didn't know what you didn't know, right? So
Right.
I love that idea. I don't know if that's something you guys could help us with, if there are key providers in your area that just maybe even starting out small and like tossing a rock into a pond, that it begins to grow a little bit, but keeping it relevant, not overly meeting or any sort of burden, but just would be really curious. And then also, what efforts are happening at the community level, grassroots, of getting folks, to your point, signed up on Medicaid or these programs, to make sure that they, I guess I'm surprised to hear that you only served 5. I feel like if we kind of looked at the uninsured numbers in Illinois, I'm sure it's higher than 5. And how could we, connect those folks that are oftentimes eligible for services that are going uncared for just because of, you don't know what you don't know. So.
Yeah.
So I would be very interested too. Jason, you mentioned the CCBHCs or CCBHOs, and the, you know, the state's effort around the CCBHCs. I think the waiver ends this year, right? December of 2025, so that federal funding will shift more to the state. Is that accurate? Or am I thinking of another state? I might be thinking of another state, so I probably shouldn't even bring it up, but I was just wondering how the state, have you heard anything around how the state plans to handle that transition over to the state budget? And kind of that federal demonstration, the way it's going to end?
Well, it just started in October in Illinois, so I'm not sure how long it goes for.
Okay, all right, so I must be thinking of, I'm probably stuck on Missouri, and I'm sorry if I a neighboring state right now.
Yeah, and I think that, I mean, it's hard to predict what federal funding streams will exist. You know, I mean, so like that's um there's so much variability and volatility right now of like even what's going to happen with Medicaid and stuff. So I think it's hard for anyone to know, you know.
Yeah.
I didn't expect, you know, a year ago today, if you told me SAMHSA wouldn't exist anymore in a year, it's like I probably wouldn't have believed you. So it's kind of hard to like predict that whole area right now, but I will say that you know, from the state association side of things, I think our belief would be that the CCBHC funding model needs to continue, and if that's not going to be federally funded, that should be a state priority.
Yeah, yeah. And like I said, I'm sorry, I was probably thinking, and I know now I was thinking about Missouri, and theirs is ending in 2025. And it's kind of a little bit in the gray right now as to how their transition plan and how it's going to transition fully to the state. But thinking about, you know, one of the things we're thinking about is how can we plan, what are the contingency plans, you know, if there's a budget shortfall, and how can we as health plans, you know, work with these CCBHOs and CCBHCs to help compensate for some of that so that we can kind of keep everything, all the good work going.
Well, so functionally, and I mean, I would like to hear your insight on this. To me, the CCBHC funding model is a like fee for service 2.0 model. It's still fee for service, right? It's just there's more of a rapid feedback loop of actual costs per provider, and then also taking into account a per cost rate that includes downtimes, whereas I think the fee for service model that has been available in the state of Illinois basically incentivizes operators to focus on high volume times and to not provide services in low volume times. I mean, that's the unintentional consequence of that. So what we found in like Winnebago County, when the sales tax first became available, we didn't have 24/7 admissions to our crisis facility, because when your productivity standard needs to be 5.5 hours per day of billable service, you can't afford to have a clinician, a master's level clinician, you know, working the midnight to 8 a.m. shift. They might get one. So I think the CCBHC is one potential way to address that, which is say, okay, we'll calculate all of your operational costs for the totality of that 24/7 hour period, and then we're going to give you a per episode basis repayment that is average cost, basically. I think there's other ways to fill the gap. I mean, you know, besides that, but it is just at the end of the day, it's just that these providers need more money to operate services outside of just their really high volume times. And if it's a community or state value, or even a public health benefit to have crisis services and other services available outside of high volume times, there has to be a mechanism to pay for capacity. Yeah, not just for the productive service.
I agree. I don't think fee for service has ever created that level of quality or sustainability for any organization. So it's never been a balanced approach. I've seen some good models that, some of these CCBHC models are moving to, yes, they still have the fee for service component for some of the lower end BH services, but then they have the wraparound and the PPS rate too. So that's kind of rich in making them whole right now. But there again, it's part of that demonstration, and that demonstration in certain states is going away, and kind of figuring out, can we move as health plans to more of that episodic basis, or is there going to be that standard PPS and maybe some sort of value-based payment that health plans can do with organizations to make them a little bit more whole.
Yeah.
Yeah, fee for service, when you think about it from a philosophical perspective, I mean, you're basically, you only get paid if you do something, if you deliver a service. So the more services you deliver, at the end of the day, I mean, that's how you generate dollars. And where we kind of make, I think a lot of times we have a hard time making that, whether it's us being a payer or even from the provider side, is how do you sort of, if you will, dollar cost average out those, it's it's the little things, it's the outreach, it's the engagement, it's trying to go find Jason. But I can't deliver a service to Jason if I can't find Jason. And so those other things, and there's a lot of value, I think, and certainly quality, if we can find the Jasons, not to pick on you, but if we can find you and get you the services that entire, as you said, that episode of care there's value in all those things. And there's not typically a CPT code that aligns with that. And so to your point, sometimes when we're asking providers as a payer and plan, we want you to do more, to take care of the member. But a lot of that stuff is just, it's, I always equate this to a tombstone. There's a birth date and a date of death. The dash, that's where all the good stuff happens. That's the life. That's all the stuff in the middle. And we just have a hard time capturing and characterizing those things. And I just feel like when we talk about this a lot, that Humana has been very good at doing value-based opportunities with PCPs in primary care. It's getting into that specialty niche, and particularly in BH, where we're seeing in every single state opportunity we have, behavioral health is huge. SUD, suicidality, the unsheltered, the opioid crisis. We're seeing this, and we're going to have to do more collectively to pay for these wrap services to get the outcomes that we want. And so it's just kind of an interesting concept. And I sure do hope that CCBHC model is here to stay. I feel like, depending on what happens, those that have money or got money this year, use it wisely. I'm not sure what's going to happen in the future. But I do love their model and those 9 core components. And I do believe that's kind of where a lot of the crisis services are going to live. Do you agree, Jason, that many of these CCBHCs now, that's going to be part of their expectation, is for these crisis services to really be them sort of have the lion's share of these in the various areas they exist?
Yeah, I think so. I think the CCBHC vision is to have an emergency drop-off center that's basically 24/7, like not exactly an emergency room, but at least like somewhere between an urgent care and an emergency room for behavioral health. And but some of the challenge even with that is, I think the crisis residential is not part of the CCBHC funding. And we've had a crisis residential facility here in Winnebago County that has, let's say it's 16 beds. So it's got that capacity for inpatient, and then it's got a limited capacity for triage, lower capacity for triage. One of the challenges that I think our local CCBHC is facing is, how do they build a facility that can meet the CCBHC vision of emergency drop off, but still maintain these beds? And then if the beds become relocated, and let's say they're part of a facility that has substance use beds or something, does that then put them into the category of hospital and not crisis residential and things like that. So there's still challenges with that on the crisis side in terms of what that looks like, because the CCBHC vision or the CCBHC funding, as I understand it, does not include the crisis residential. So that becomes, not that it can't exist somewhere, but it's not part of that. So then that part still needs to get funded and can through the state, but then that has its own kind of, so I don't know. I think we're all trying to figure it out still is the quick answer.
When you say crisis residential, is it more like crisis stabilization units with maybe an average length of stay of 3 to 5 days? Or is it longer?
Up to 2 weeks.
Okay.
Yeah, I think the CCBHC wants the crisis stabilization 3 to 5 day thing. Yeah.
Yeah,
But we have the crisis residential. That's kind of in the state Medicaid, you can have that for up to 14 days. But you can only have 16 beds, up to 16 beds in a facility. Otherwise it becomes a hospital.
Yeah.
If you have more
That's the
than 16
IMD
beds.
rules. Yeah. What facility is that in Winnebago County?
The Mulberry Center.
Perfect.
So right now they have 16 beds, a living room, and a triage.
Yep. So that's let me look at, and that is sorry, I've got a list of residential crisis service providers and I don't see Mulberry on there. So that list that's on the state's website may be a little out, but I do want to. What's that?
Rosecrans.
Okay, that's it. Thank you. That's on the list.
Yep.
Yep, that's perfect. Now I'll be honest, Dana and I are a little bit on a journey of discovery. One of the things we have an internal work group, and we're really trying to unpack the crisis continuum in Illinois, because it is, I'll just say it's a little different. It's a little clunky for me to understand. I've been doing this a long time, and so we're trying to understand that difference between what we see the requirements of the mobile crisis. We see crisis stabilization, that term used a little bit loosely, and then we're seeing the crisis residential, and really just wanting to make sure and unpack that continuum, because I really feel it's going to be important for us to understand that, to know where we can interact, if you will, whether it's care management, care coordination, or such, with the progression points of our individuals, in crisis, and then hopefully what can we do maybe to prevent them from being in crisis. So I appreciate that information about the 16 beds there. We're going to probably visit. I think that's on our listening tour, Dana.
Yeah,
Rosecrans is on there.
So I know we only have a few minutes left, and I really have enjoyed this conversation. And again, we'll go back to, I wish I had joined 15 minutes before, so I did. But I guess it's going back to reentry, or not reentry, but the jails and getting mental health treatment and services within the prison system. One of the things that I have seen as a successful model in other states was when health plans are able to kind of get in and also coordinate services. Is there opportunity that you think where health plans could maybe step up a little bit more on the reentry front, now that Illinois allows that 90 days pre-release interaction? Do you see a lot of activity going on that's successful to transition them out and make sure that they have the wraparound supports that they need when they get back into the community?
So, sorry, Debbie, go ahead. If you, I would just say, I think probably the answer is yes, but the nuance to it is that nobody gets a 90-day discharge date. So like people don't know, like, how do you predict when it's going to be 90 days from discharge? Usually from what I hear from our criminal justice providers, like discharge happens fast. And we don't know until we do know. And then when we do know, it's happening now, not this person will be discharged in 30 days from now. So, you get into court and the judge is ruling based on whatever's been presented that yes, this person's eligible for discharge, and it might happen that same day. So there's a possibility, but I think that's the nuance. Is the challenge is, when does the 90-day clicker start? How do you know when you're in that window where you can start working with them? we've had the luxury here to have the sales tax, and we've been able to fund comprehensive mental health, behavioral health, MAR, 5 clinicians, discharge planner, all in our jail. And I mean, it's working really well. We've had people who have been restored to fitness in the jail while waiting for a bed to open up in the state hospital, just because the services are available. But again, that's a luxury we have with the local sales tax. Most do not have that, and I think getting more resources in the jail would be critical. It's just that discharge date is really hard to predict from what I understand, what I hear from those working in criminal justice.
Yeah, I know they get a disposition date, but you're right, it can be a moving target too. But I was just wondering, you know, the value of and where we would kind of have like that reentry coordinator to start that connection, because we don't want them to fall through the loop on our end. If, you know, they're going to be assigned to a Humana, United, or wherever they end up at, you know, we definitely need to, it's always been a gray area. Where do we start having those conversations to kind of have those connections?
I wonder, you know, for us, you know, we contract with a medical provider that's there. We just renewed a contract or started a new contract. We'd been with someone, our jail had been with someone for quite a long time, and they just started with somebody new. And again, that's where our behavioral health person works in conjunction with their medical staff there. I mean, it's a private organization, Centerstone of Illinois, and but they coordinate through the medical personnel there, everything in terms of the clinician being there and how the person's assessed on or screened on intake, and then how the referrals are made to the clinician. But to me, it's like discharge planning should start when they walk in the door. I mean, because you don't know the timeline, back to Jason's point, you don't know how long it's going to be till the disposition. So I think addressing that right up front, you know, where are we going to connect them when they are going out? And that's part of what our clinician thing is, to work on reentry and to at least get them into one of the major behavioral health centers when they are released. And so far, I can't quote you the data, but they've been doing really well with that reentry piece of it.
Great. And then trying to figure out, I guess, like I said, where we insert our care management, our case coordinators, to ensure that they get like the value added benefits. We can set up like apartments and rent and, you know, whatever else, whatever other wraps and services that that they need, that maybe aren't necessarily fully being coordinated at or even just supporting the behavioral health center where they're, you know, discharged and set up for their next appointment with.
And you know, those things might have to go through the Department of Justice if it's going to be all throughout Illinois. Now, I can say individually, our jail, our previous sheriff would have nothing to do with anything behavioral health. We have a new person, it's been there 2 years now, and just totally embraces. We've swung just the opposite way, and they want to bring anything in that would benefit anybody with mental health issues, because their officers are dealing with it and they're not trained to deal with it. And so they feel like this is such a benefit to have individuals on site there. So, you know, you've got that to deal with. And so, I mean, individually, you could do that individually with each geographic or jurisdiction. But if you could get something through Illinois, a partnership developed, that you've got that where you can go in and work with anybody.
Yeah, you're probably right. It probably is going to be like one by one, because I know each county is a little different. So yeah. All right.
Looks like
Well,
Sean had to hop off here, so.
yeah. Well, I really do appreciate the conversation and the wealth of information. I do hope, and I would love to explore maybe setting up some sort of roundtable opportunity, because I do think that there's great benefit in that. So I'd love to reach out, or Shannon or Dana, on the back end as a follow-up, if that's okay.
Sure. I mean, yeah, we can, and we'll present it to our board and go from there. That would be great.
Okay, all right.
Appreciate your time. Thank you so much for sharing with us, and thanks Jason and Debbie for joining us today.
Thank you.
So much.
Have a good afternoon.
Bye.
Bye.
You too. Bye.